Welcome to the deep dive. Our mission here is, well, it's to take complex information, the stuff often buried in long documents, and really boil it down.
Yeah, we pull out those crucial insights, maybe some surprising facts, and definitely the actionable knowledge you need so you feel well informed quickly.
Think of us as your accelerated guide. We're here to walk you through the really essential source material, highlighting what truly matters.
Especially when you're a specialist clinician, right? Navigating these critical situations where, well, information is power.
And today, we are doing a deep dive into exactly that kind of critical area, the management of vascular trauma.
Our source for this is the Comprehensive European Society for Vascular Surgery 2025 Clinical Practice Guidelines on the Management of Vascular Trauma. It was published in ESVS Open Access.
And it's a major update, isn't it? Giving that evidence-based guidance in a field where, frankly, decisions have huge consequences.
Oh, absolutely. And this isn't just some casual paper. It's the result of immense effort by a large multidisciplinary group of experts from all over, really.
We should probably touch on the methodology behind these guidelines, too. How they searched the literature, how they decided on the strength of evidence, how they graded recommendations.
Definitely. Understanding that foundation is, well, it's key to knowing how much weight to give each piece of advice you find in there.
And the scope is pretty broad.
It really is. We're talking everything from the fundamental principles like who gets these injuries, who should be doing the surgery, how we resuscitate right through to the specifics of injuries in the neck, the thorax, abdomen, extremities.
It covers the whole spectrum of treatment, too, doesn't it? Open surgery, endovascular stuff, even when not to operate.
Exactly. And special populations, like kids, post-op care. And importantly, they're quite upfront about where the evidence is still, well, a bit thin.
Which, for you listening, dealing with these high-stakes scenarios, having this updated framework isn't just helpful.
No, it's pretty essential, really, for optimizing outcomes when you're facing those life or limb decisions, often under serious pressure.
So our goal today is to methodically unpack these guidelines. We'll go through the key principles, the recommendations, explore the nuances, the evidence.
Or sometimes the lack of evidence.
Right, and the practical implications for your practice. We'll get into the European Society for Vascular Surgery's new grading system for these injuries.
The Class 1, 2A, 2B, 3 recommendations.
And the levels of evidence A, B, C that underpin them all.
It's a dense document, no doubt. But if we break it down piece by piece,
we can get to the heart of what's important. Okay, let's unpack this. Let's start right at the beginning. How are these guidelines actually put together? And why does that matter for how we, interpret them?
understanding the methodology is, well, it's vital. It tells you the rigor behind every statement. The introduction section, it makes it clear their aim is to help physicians pick the best strategies.
But they're guidelines, not rules.
Exactly. They stress that. They're not legal standards. Clinical judgment, consider the individual patient, the specific circumstances, that always comes first.
And they're aiming this at a pretty wide audience involved in trauma care.
Oh, yeah. Vascular and trauma surgeons, obviously, but also trainees, anesthetists, intensivists, radiologists, emergency docs, plastics, orthopedics. It takes a village, essentially.
It's a team sport.
Totally. And they emphasize these guidelines build on established principles. Things like advanced trauma life support, damage control concepts.
Yeah.
Stuff that's already fundamental in trauma.
And the writing committee itself.
Large, multidisciplinary, international, which, adds weight to the consensus view, especially in areas where you don't have tons of high-level randomized trial data.
So how did they actually gather all the information?
They did a systematic literature search, focused mainly on English language papers from 2000 up to early 2024. Used the major databases, Medline, Embase, Cochrane.
And they prioritized the evidence.
Yeah, using that pyramid approach. So systematic reviews, meta-analyses at the top, then randomized trials, high-quality observational studies. Importantly, for trauma, they generally excluded things like single-case reports or animal studies, unless it was something really groundbreaking.
So a systematic approach to get the best available data.
Right. Which brings us to, well, the core of their whole framework. That grading system for evidence and recommendations. This is super important for reading the rest of it.
Okay, break it down for us.
So first, the level of evidence, 3 tiers. Level A, that's your strongest evidence, coming from multiple randomized trials or meta-analyses. Level B, based on maybe a single randomized trial, or good quality non-randomized studies, think large prospective registries, that kind of thing, or a meta-analysis of those. Still good evidence, just maybe not quite as bulletproof as multiple trials. Then level C, this is based on expert consensus, Or lower quality studies like small retrospective
Yeah.
series, maybe case series, or meta-analyses of those. And in trauma, you'll see quite a few recommendations based on level C, just because doing big trials is really tough in this field.
So level A is like, definitely do this, the trials are clear. Level B is solid data suggests this is a good idea. And level C is more, the experts agree or the smaller studies lean this way, so it's reasonable.
That's a good way to think about it.
Yeah.
Then, for the class of recommendation, they've got this 5-tier system, really critical for understanding how strongly they're advising something.
Okay.
Class 1. This means there's good evidence or strong agreement that a treatment is beneficial, useful, effective. The wording you'll see is recommended or are recommended. This is the strongest call to action.
Got it. The top tier.
Then Class 2. This indicates there's maybe conflicting evidence or some difference of opinion. Within Class 2, you have Class 2A. Here, the weight of evidence or opinion favors usefulness. The wording is should be considered. So it's leaning positive, but not quite as definitive as Class 1.
So a strong maybe consider this.
Yeah. The Class 2B. Here, usefulness is less well established. The wording is may be considered. This is a weaker suggestion, right? Acknowledging more uncertainty.
A weaker maybe?
Exactly. And finally, Class 3. This means there's evidence or agreement that a treatment is not useful or effective, and maybe even harmful. The wording is not recommended. This is a clear signal to avoid that intervention.
Okay, so let's run through that again. Class 1 is recommended, definite yes. Class 2A should be considered strong maybe. Class 2B may be considered weak maybe. And Class 3 is not recommended, clear no. Understanding that is vital.
It really is. It's like your decoder ring for the whole document. And for every single recommendation, they give you both the class and the level, often with tables summarizing the evidence they looked at.
And they use quality reporting standards, peer review plan updates. Sounds thorough.
Yes, they followed good practice, aiming to keep it current. But crucially, they are very upfront about the limitations.
Which are?
Well, they state pretty clearly there's a general lack, a paucity, of high-quality data in vascular trauma overall, especially when it comes to things like differences based on sex, ethnicity, or the specific challenges you face in low and medium-income countries.
That's a really important caveat, isn't it, for applying these guidelines in the real world. You can't just take a recommendation made based on, say, European data and apply it wholesale everywhere without thinking.
Precisely. You have to consider your local context, your patient population, the resources you actually have. They also note the guidelines don't specifically cover military or humanitarian settings in detail, and they didn't formally assess things like implementation barriers or the cost-effectiveness side.
So the methodology tells you how solid the ground is for each recommendation.
And the limitations remind you where you might need to tread a bit more carefully, use more clinical judgment.
Okay, quick pause. Let's recap this foundation. These guidelines are a major international multidisciplinary effort. They used a systematic search and a very clear grading system. Class 1 recommended, 2A should consider, 2B may consider, 3 not recommended, backed by evidence levels A, B, or C. This framework is key.
But crucially, they're honest about the gaps in high-quality evidence, especially for diverse groups and settings, reminding us that clinical judgment tailored to the specific patient and situation is always paramount.
Right. That really sets the stage for understanding the broader principles of management they discuss next.
Okay, let's move from how they did it to what they found regarding general considerations. First up, epidemiology.
We know vascular trauma is a big deal globally, causes a lot of death and disability, but the guidelines really emphasize how much the picture varies, right?
Hugely. Depends on the population, the mechanism of injury, how severe it is, the healthcare setting, urban, rural, military. Data mainly comes from countries with big trauma registries.
And the incident.
Roughly 2 to 5% of all trauma admissions. One major European center reported 4.4%. It hits young males most often. It's less common in older adults and kids, but when older folks get these injuries, it's often more severe, typically blunt trauma.
And the cause matters a lot. Penetrating versus blunt.
Big difference. Penetrating injuries, stabs, gunshots are more common in urban areas. Gunshot wounds, in particular, have a high rate of vascular injury, up to 16% in some series, and they tend to lead to worse outcomes if vascular repair is needed.
And blunt trauma.
More common in rural settings, car crashes, falls, industrial accidents. These patients generally have more severe injuries overall, higher mortality, higher limb amputation rates compared to penetrating trauma patients.
Where on the body do these usually happen?
In civilian settings, extremities are most common. Almost half the cases split fairly evenly between upper and lower limbs. Then the torso is next, about half the cases, split between abdomen and chest. Neck injuries are around 10%.
And the type of injury influences location, too.
Yeah, penetrating trauma survivors often have more extremity and junctional injuries. Groin, axilla. Blunt trauma tends to cause more central vascular injuries, like in the chest or abdomen.
The mechanism really dictates the damage pattern, doesn't it?
Absolutely. A knife or gunshot can just cut right through a vessel. A broken bone can tear it. High-velocity gunshots cause damage from the energy transfer even without a direct hit. Blunt trauma, like stretching or pinching, can cause these intimal tears inside the vessel wall that lead to clots. They give examples like specific fractures being linked to vessel injury, or deceleration causing blunt aortic injury at the isthmus, or even seatbelts causing abdominal aortic injury.
Military and terrorism settings are different again.
Yeah, much higher prevalence in conflicts, up to 18% of injuries, often multiple vascular injuries per patient. Extremities dominate there. Blast injuries cause really complex, multi-level damage patterns.
This variability leads straight into a really critical question.
Yeah.
Who should actually be performing vascular trauma surgery?
It's a huge point. Managing these life or limb-threatening injuries needs a very specific skill set. It often happens out of hours, requires quick, accurate decisions and interventions.
But the training and experience aren't always there.
That's the challenge the guidelines acknowledge. Training varies. There's a growing consensus that maybe non-vascular residents shouldn't be playing a major role in the complex stuff, but then again, many vascular surgeons don't have extensive acute open trauma experience, and emergency general surgeons often have less open vascular training these days.
So there's a gap.
There is, and it highlights the need for workforce planning and specific training solutions. Maybe trauma general surgeons in high-volume centers can handle some penetrating injuries, but often lack endovascular skills. Pediatric vascular trauma is so rare it almost always needs combined specialty input.
It really emphasizes the need for a multidisciplinary team.
Absolutely. For most centers, it's about having general surgery, vascular surgery, and interventional radiology working together seamlessly, which leads to a really fundamental recommendation.
Okay, what is it?
Rapid access 24/7 to a team competent in hemorrhage control and both open and endovascular surgery is recommended for life or limb-threatening injuries. That's Class 1, Level C. Expert consensus on a vital structural need.
So access to the right people is number one. What about the training for those people?
Also critical. Recommendation 2. Implementation of civilian and military vascular trauma curricula and dedicated training are recommended for decision-making and technical skills maintenance. Again, Class 1, Level C.
What kind of skills are we talking about?
It's a broad set, different from elective surgery. Things like rapid exposure and control of major arteries and veins everywhere, chest, abdomen, neck, limbs, damage control techniques, getting clots out, primary repair, putting in shunts, ligation, fasciotomy, even amputation, definitive repair techniques, endovascular stuff, and anastomosis using grafts.
Sounds challenging to maintain, especially outside busy centers.
It is. You need to be comfortable starting surgery in a patient who's bleeding heavily, maybe decompensating. They mentioned simulation, cadaveric labs, animal models as training methods, and crucially, teamwork. Trauma surgery is complex, involves many professions. Training in leadership, communication, working smoothly in that team is vital. Ultimately, dedicated time in high-volume trauma centers with regular refreshers seems necessary.
What about the role of endovascular therapies? You mentioned the team needs those skills too.
Yeah, their use is definitely increasing, maybe up to a quarter of patients now, mostly those who are hemodynamically stable.
Advantages.
Less invasive, potentially lower morbidity, but limitations too require specific anatomy, suitable access vessels. It's generally less suitable for patients who are actively crashing and need immediate open control.
Although hybrid approaches are changing that.
Exactly. The guidelines talk about the evolving role of emergency hybrid operating rooms. Rooms equipped for both open and endovascular procedures simultaneously. These allow multimodal approaches, maybe reducing time to definitive control if they're properly located and staffed. Access to an operating room with hybrid capability is recommended, Class 1, Level C, for treating trauma patients with vascular injury.
Okay, let's take a quick pause here. We've covered the big picture, the epidemiology, who gets hurt, how, where. We've tackled the crucial who does the surgery question, emphasizing specialized skills, teamwork, and leading to those Class 1 recommendations for 247 access and dedicated training. We also touched on the rise of endovascular and the importance of hybrid rooms, another Class 1 recommendation. This sets the stage nicely for how we initially manage the bleeding and resuscitation.
Right. So resuscitation in vascular trauma follows modern damage control resuscitation principles, the same as for any severely bleeding trauma patient. The goal is to prevent or treat coagulopathy and the badness that comes with massive bleeding and shock. P principles are permissive hypotension, not pushing the blood pressure too high initially, hemostatic resuscitation using whole blood or balanced components like packed cells, plasma, platelets, and damage control surgery, getting in quickly, stopping the bleeding, getting out, and fixing things definitively later.
And the guidelines found no reason to do anything different just because it's a vascular injury causing the bleeding.
Correct. No specific evidence suggests different principles, which leads to two very strong recommendations, both based on level A evidence, the highest level.
Okay.
First, damage control resuscitation principles and massive transfusion protocols for traumatic hemorrhage are recommended for patients with vascular trauma. That's Class 1, Level A.
And the second?
About Tranexamic Acid, or TXA. Early administration of Tranexamic Acid is recommended for all severely bleeding patients with vascular trauma. Again, Class 1, Level A, based on trials like CRHH. Give it early.
Okay, solid guidance there, strong evidence. What about physically stopping bleeding temporarily, like with tourniquets?
Direct pressure is always the first step for extremity bleeding. But if that's not enough or the situation doesn't allow it, like in a pre-hospital setting, then a tourniquet comes in.
Where and how?
The recommendation is a pre-hospital tourniquet, applied as distally as possible but still proximal to the wound, is recommended for uncontrolled extremity bleeding when local methods are insufficient. That's Class 1, Level C.
And a specific point about heparin.
Yes, very specific. Heparinization is not indicated as part of tourniquet management in patients with uncontrolled bleeding from extremity vascular trauma. That's Class 3A, Level C. Basically, don't give heparin while you're trying to stop uncontrolled bleeding with a tourniquet.
Right, makes sense. Now let's talk about REBOA, resuscitative endovascular balloon occlusion of the aorta. Big topic lately.
It's a huge topic, used for uncontrolled, non-compressible torso trauma, which has incredibly high mortality. The idea is it's a temporary bridge putting a balloon in the aorta to stop bleeding proximally until you can get to definitive surgical control.
But there are caveats.
Big caveats. It should not delay definitive control. And patient selection is really difficult. Who benefits? When exactly do you put it in? There's conflicting data from observational studies.
And the key randomized trial.
The UK REBOA trial. This compared a strategy of in-hospital REBOA plus standard care versus standard care alone in the emergency department. The results were, well, striking.
How so?
REBOA did not reduce mortality. In fact, it might have increased it. 90-day mortality was significantly higher in the REBOA group, 54% versus 42%. The odds ratio pointed towards harm.
Wow. That's a major finding influencing the guideline.
Absolutely.
Yeah.
It leads to a very strong recommendation against routine use. Recommendation 8. REBOA is not recommended as a routine approach for temporary hemorrhage control in trauma patients with exsanguinating torso hemorrhage. That's Class 3B, Level B. The Level B is because it's based on that important randomized trial data.
Okay, shifting from stopping bleeding to finding the injury, diagnosis.
For hemodynamically stable patients, computed tomography angiography CTA is the absolute workhorse. Its sensitivity and specificity are near 100% for significant injuries.
So it's a go-to test.
Yes, if the patient is stable enough. Recommendation 10. CTA, including arterial and venous phase, is recommended as the first-line investigation to identify or rule out vascular injury in patients without clinical signs of active bleeding. That's Class 1, Level C.
What about concerns about kidney injury from the contrast?
That's addressed directly. Recommendation 11. Avoiding or postponing CTA due to possible renal impairment is not recommended in stable patients with potentially life or limb-threatening injuries. Class 3B, Level C. The rationale is the risk of missing a critical treatable injury far outweighs the generally very low risk of contrast-induced kidney problems in this high-stakes situation.
Got it. And just to reiterate, the ankle brachial index, or ABI, we mentioned it earlier.
Right, they circle back to it later, but it fits here. Recommendation 83. An ankle brachial index is not indicated to diagnose or rule out vascular injury in patients with extremity trauma. Class 3A, Level C. So don't rely on ABI in the acute trauma setting for diagnosis.
Okay, so for stable patients, CTA is last one recommended. Don't worry unduly about kidneys, class 3B. Don't use ABI, class 3A. What if the patient is unstable and can't go for a CTA?
Straight to the operating room. Recommendation 9. Hemodynamically unstable patients unsuitable for CTA are recommended to be immediately transferred to the operating room for surgical intervention. Class 1, Level C. Stability really dictates that initial pathway.
Now, these guidelines introduce a specific grading system for arterial trauma. Can you walk us through that? It seems important for understanding the later recommendations.
Yes, it's the ESVS grading system, based on previous ones, but adapted for current treatments. It helps standardize how we talk about injury severity. There are basically 4 grades.
Okay.
Grade 1. The injury is just confined to the inner layers, the intima, or the vessel wall itself. The outside shape of the vessel looks normal on imaging. Think intimal flap, intramural hematoma. Management is generally observation, maybe with some antithrombotic medication.
Grade 1, minor, contained within the wall.
Right. Grade 2, now you have a complete wall injury. The external contour, the outside shape, is abnormal, but the bleeding is still contained. Examples are a pseudoaneurysm or an arteriovenous fistula, AVF. General management here is urgent repair.
Grade 2, through the wall, but contained bleeding. Needs fixing.
Exactly. Grade 3. This is also a complete wall injury, but now the hemorrhage is uncontained. It's active bleeding. Think blunt arterial transection or a penetrating injury that's actively bleeding out. This needs emergency repair right away.
Grade 3, active, uncontrolled bleeding. Emergency.
Correct. And finally, grade X. This just means the vessel is occluded, blocked. Management depends on whether that occlusion is causing ischemia downstream.
So, grade 1, minor wall. Grade 2, contained leak. Grade 3, active leak. Grade X, blocked. That framework guides the treatment choices.
Precisely. It gives you a structured way to think about the severity and what needs doing, which leads nicely into the priorities of management.
Okay, you found the injury, maybe stopped the initial massive hemorrhage. What's the absolute next priority?
Restoring inline arterial flow. Getting blood flowing again to a limb or an organ that's threatened by ischemia. This is a second major priority after controlling active hemorrhage.
And this takes precedence over other things.
Yes. Recommendation 12. Restoration of inline arterial flow, temporarily or definitively, is recommended to be prioritized in the management of limb or end organ-threatening vascular trauma. Class 1, Level C. This means you should prioritize fixing the artery, or at least putting in a temporary shunt before things like stabilizing fractures or even doing a fasciotomy.
Why before fasciotomy? Isn't compartment syndrome urgent?
It is, but compartment syndrome is largely a reperfusion injury. It happens after blood flow is restored to ischemic muscle. So restoring the flow is the first step needed to even cause and then manage compartment syndrome. Fixing the artery comes first.
Makes sense. How do temporary vascular shunts fit into this prioritization?
They're a key part of the damage control strategy. You use them to rapidly restore blood flow when you can't do a timely definitive repair right away. Maybe the patient is too unstable physiologically, or there's a complex fracture that needs stabilizing first, or maybe the right expertise isn't immediately available.
So shunts are the bridge.
Exactly. Recommendation 14. The use of temporary vascular shunts to rapidly restore blood flow is recommended when timely, primary definitive vascular repair is not feasible due to patient physiology or injury pattern. Class 1, Level C. It's the practical, life-saving alternative.
But the ideal is still.
The ideal is definitive repair straight away, if possible. Recommendation 13. Primary definitive repair for patients with vascular trauma is recommended over temporary solutions. Class 1, Level C.
Okay. If you do use a shunt, how long can it stay in? When do you convert it?
The data on duration isn't great. Complications seem to go up after about 6 hours, based on limited studies. Ideally, you'd convert it to a definitive repair during that first operation. If that's not possible, then as soon as the patient is stable enough and realistically within about 12 hours. Recommendation 15 suggests conversion should be considered as soon as possible, ideally at the primary operation. Class 2A, Level C.
What about graft materials for the repair, if you need a graft?
Autologous vein is generally preferred, especially for extremities. But sometimes you don't have good vein, or there's significant tissue loss or contamination. In those emergency situations, Recommendation 17 says synthetic interposition grafts may be considered. Class 2B, Level C. It acknowledges the risks, but also the practical needs sometimes.
Okay, let's take a breath. That was a lot on general principles. Quick recap. Modern resuscitation with TXA, Class 1, Level A. Tourniquets okay pre-hospital, Class 1, but no heparin with them, Class 3A. REBOA is not recommended routinely, Class 3B, Level B evidence. CTA is key for stable patients, Class 1. Don't delay for kidneys, Class 3B. Don't use ABI, Class 3A. The ESVS grading 1, 2, 3X is foundational. Top priorities. Stop bleeding, then restore flow, Class 1. Use shunts when needed, Class 1, but aim for definitive repair, Class 1. Synthetic grafts are an option, Class 2B.
Yeah, that covers the core principles. Stability-driven decisions, evidence-based resuscitation, good imaging, and clear surgical priorities like damage control and restoring perfusion. That foundation is essential before we dive into specific body regions.
Right. Let's narrow our focus now and move up to the neck, starting with penetrating injuries.
Okay. Penetrating neck injuries are pretty common. They can present with those classic hard signs, a rapidly expanding or pulsating hematoma, severe bleeding, shock, absent pulse, maybe a bruit or thrill, neurological deficit.
Or sometimes more subtle, soft signs.
Exactly. Things like vomiting blood, minor coughing up blood, hoarseness, difficulty swallowing, or maybe just a non-expanding hematoma. And stroke is always a major concern, either right away or developing later.
Now, historically, we divided the neck into zones for management, but the guidelines suggest a different approach now.
They do. They really advocate for a whole neck approach, moving away from those classical 3 zones.
Why the change?
Well, partly because wound tracks often cross zones anyway, injuring things in multiple areas. And with modern CTA being so good, systematic reviews support assessing the whole neck comprehensively with imaging. It improves diagnostic accuracy and means fewer negative surgical explorations, fewer times opening the neck unnecessarily.
So for penetrating neck injuries, think whole neck assessment, use CTA to guide you, don't get too hung up on the old zones.
Pretty much. Now let's look at specific vessels. Penetrating carotid artery injury. What if it's minor, like an ESVS grade 1? Just an intimal tear, the outside looks normal.
What's the approach?
These are often found on CTA, maybe from proximity injury from a gunshot. The reported management strategy is often non-operative, maybe with just antithrombotic therapy alone.
Yeah.
The evidence isn't strong on which agent, but it tends to favor a single antiplatelet. So, recommendation 21. Non-operative management with single antiplatelet therapy may be considered for minor ESVS grade 1 carotid injury due to penetrating trauma. That's Class 2B, Level C, reflecting that lower quality evidence.
Okay, may consider for minor ones, but what about the more severe penetrating carotid injuries, grade 2 or 3, with contained or active bleeding?
Here the data is much more compelling. Just tying off, ligating, the common or internal carotid artery carries a really high risk of stroke and death.
Significant risk.
Huge. Registry data shows much lower mortality if you reconstruct the artery versus just tying it off. One data set showed in-hospital mortality for internal carotid injury reconstruction was 7% versus 25% for ligation. Another study showed dramatic neurological improvement in patients who got repair compared to poor outcomes with ligation.
So the recommendation must be strong for repair.
Absolutely. Recommendation 22. Reconstruction, rather than ligation of the common or internal carotid artery, when patient physiology allows and it's technically feasible, is recommended in patients with penetrating ESVS grade 2 or 3 carotid artery injury. That's Class 1, Level C. A very strong recommendation driven by those big outcome differences.
Okay, moving across to the vertebral artery, also in the neck. What about penetrating injuries there? Minor ones first, grade 1.
Similar approach suggested as for minor carotids. Recommendation 23. Non-operative management with single antiplatelet therapy may be considered for an ESVS grade 1 vertebral artery injury due to penetrating trauma. Again, Class 2B, Level C, reflecting limited evidence.
And for more significant vertebral injuries, grade 2 pseudoaneurysms or grade 3 active bleeding.
Here, surgical repair is technically very difficult because access is tough. So endovascular techniques really come to the forefront. They're seen as the first-line approach for most of these.
Specifically,
For active bleeding, grade 3 embolization is key. Recommendation 25. Emergency endovascular management with embolization, if feasible, is recommended for patients with penetrating extracranial vertebral artery injury and uncontrolled hemorrhage, ESVS grade 3. Class 1, Level C. You basically plug the bleeding vessel from the inside.
is sacrificing the vertebral artery safe?
Often, yes. The stroke risk is relatively low, around 4% if the other vertebral artery and the brain's collateral circulation are intact. The risk is higher if you have to embolize very distally near important branches. For contained injuries like pseudoaneurysms, grade 2, embolization is also often the first choice or sometimes covered stenting.
Okay. And quickly, venous injuries in the neck, like the internal jugular vein.
The decision is often repair versus ligation here too. Recommendation 27 gives practical guidance. Ligation is recommended if repair of internal jugular vein injury is not easily achievable, provided one internal jugular vein remains patent. Class 1, Level C. Essentially, if you can preserve outflow from the brain through the other side, ligation is acceptable if repair is tricky.
Okay, let's pause for a quick check-in. We just covered penetrating neck trauma, key points. Move towards a whole neck assessment with CTA. For significant carotid injuries, grade 23, repair is strongly recommended over ligation, class 1. For minor penetrating carotid or vertebral injuries, grade 1, non-operative management with antiplatelets may be considered, class 2B. And for actively bleeding vertebral injuries, grade 3, embolization is the recommended first-line approach, class 1, plus that guidance on jugular vein ligation, class 1.
That sums it up well. Now let's shift to blunt neck injury.
Blunt cervical vascular injury, or BCVI. These are injuries to the carotid or vertebral arteries from blunt trauma mechanisms, right?
Exactly. Things like high-energy car crashes, specific facial or skull-base fractures, severe TBI, neck fractures, even near-hanging or significant seatbelt marks across the neck. These mechanisms raise suspicion.
Why are they so concerning?
Because they can cause dissections or pseudoaneurysms inside the vessel wall, which might not cause problems immediately, but can lead to clots forming and causing a stroke later on.
So screening is important.
Yes. Identifying patients at risk who might need treatment to prevent stroke is key. The guidelines list those specific risk factors, the mechanism plus associated injuries based on level B evidence. They're important clues.
Who exactly should be screened, though? Is that clear?
That's still a bit debated. Different protocols exist. If you screen too liberally, you might overdiagnose, overtreat, use more radiation, too strict, and you might miss injuries. There's no definitive trial saying one screening tool is best. The modified Denver criteria are widely used and studied.
So what's the recommendation?
Given the lack of definitive evidence for one specific tool, they say institutions should implement one protocol and adjust based on local factors. But they do recommend considering screening protocols. Recommendation 30. The use of screening protocols to identify cervical vascular injury early should be considered for patients with blunt trauma. That's Class 2A, Level C acknowledging the need, but less certainty on the best way.
And if someone meets those risk criteria, what imaging?
CTA. Recommendation 29. CTA, including intracerebral vessels, is recommended for all patients at risk of blunt cerebrovascular injury. Class 1, Level C. Get the scan if the risk factors are there.
Okay, you've diagnosed a BCVI. How is it managed? Does the ESVS grade system apply here too?
Yes, management is guided by the ESVS grade, 1, 2, 3, or X. Let's take blunt carotid artery injury first. For grade 1, just at intimal tear, normal outside-shaped non-operative management with single antiplatelet therapy is recommended. Class 1, Level C. Studies support this for low-grade injuries without symptoms or active bleeding.
What about grade 2, the pseudoaneurysms? Do they need intervention?
Generally, no, not up front if they aren't bleeding. While grade 2 injuries are less likely to heal spontaneously than grade 1, the majority of blunt carotid pseudoaneurysms actually do heal over time with medical management. The crucial finding from studies is that stroke risk quadrupled and mortality increased nearly tenfold when antithrombotic therapy was withheld.
So antithrombotics are key for grade 1 and 2.
Absolutely.
Yeah.
That's the mainstay, which leads to an important do not do recommendation. Recommendation 32. The use of routine endovascular stenting as an adjunct to antithrombotic therapy is not recommended for patients with blunt carotid artery injury without active bleeding, ESVS grade 1 or 2. Class 3B, Level C. Don't routinely stent these non-bleeding, low to moderate grade injuries. Treat with antiplatelets.
When do you intervene for blunt carotid injury then?
If it's grade 3, complete wall transection with active hemorrhage, then operative treatment, open repair or endovascular stent graft is recommended. Class 1, Level C, active bleeding needs stopping.
Any other time?
Yes. Delayed endovascular treatment may be considered for patients with blunt carotid or vertebral injury, grade 2, if the pseudoaneurysm is enlarging on follow-up scans, or if the patient develops neurological symptoms. That's recommendation 33, Class 2B, Level C, so intervention for progression or symptoms.
Okay, let's switch to blunt vertebral artery injuries. How are they managed if there's no active bleeding? Grades 1, 2, or X?
Antiplatelet therapy, recommendation 37. Management with antiplatelet therapy as first-line treatment is recommended for patients with blunt vertebral artery injury without active hemorrhage, ESVS grades 1, 2, or X. Class 1, Level C.
Antiplatelets specifically, not anticoagulants.
The evidence here is interesting. A systematic review showed any antithrombotic was better than none, but didn't find a difference between antiplatelets and anticoagulants for stroke outcomes in asymptomatic BCVI. However, a more recent meta-analysis did show a lower stroke rate with antiplatelets versus anticoagulants, and importantly, a significantly lower bleeding risk with antiplatelets. Aspirin seemed particularly good regarding bleeding risk compared to heparin. There's no clear evidence favoring dual antiplatelets over single.
So the current thinking leans towards antiplatelets for non-bleeding blunt vertebral injuries.
Yes, based on that recent meta-analysis suggesting similar efficacy for stroke prevention but lower bleeding risk.
How long do you treat?
Continue for at least 3 months, or until the injury shows resolution on follow-up imaging.
And what if a blunt vertebral injury is actively bleeding, grade 3?
Same as for penetrating. Emergency endovascular embolization. Recommendation 38, emergency endovascular management with embolization, if feasible, is recommended for patients with blunt extracranial vertebral artery injury and uncontrolled hemorrhage. ESVS grade 3. Class 1, level C.
How about follow-up imaging for BCVI managed non-operatively?
Recommendation 39. Surveillance with computed tomography angiography at 1 week and 3 months should be considered for patients with blunt carotid artery injury, ESVS grade 1 or 2, undergoing non-operative management with antiplatelet treatment. Class 2A, level C. Helps track healing and guide how long to continue the antiplatelets.
Okay, wrapping up the neck then. Penetrating. Whole neck CTA, repair carotids, class 1, embolize bleeding vertebrals, class 1, maybe observe minor injuries, class 2B, blunt screen based on risk factors, class 2A RECVA protocols, class 1 for CTA if at risk, manage grade 1 blunt carotid non-up with antiplatelets, class 1, don't routinely stent non-bleeding grade 12, class 3B, intervene for grade 3 bleeding, class 1, or progression, class 2B. For blunt vertebral grades 1, 2X without bleeding, antiplatelets are recommended first line, class 1. Surveillance CTA considered for non-op carotid cases, class 2A.
You got it. It's a complex area, but the guidelines provide a pretty clear framework based on mechanism, grade, and stability, emphasizing non-operative management with antithrombotics for many blood injuries without active bleeding.
Right. Let's move down into the chest now. Thoracic vascular injuries, blunt thoracic aortic injury, BTII, is a major focus here, isn't it? Highly lethal.
Extremely lethal. Up to 80% of patients die before they even reach the hospital. It's usually caused by rapid deceleration forces, typically injuring the aorta at the isthmus, that transition point where the mobile arch meets the fixed descending aorta.
And those who make it to the hospital?
The vast majority are actually asymptomatic initially, diagnosed on imaging, but they're still at high risk of rupture, especially in the first few hours after admission. One study showed almost 9% ruptured within 30 hours.
So initial management is critical.
Absolutely. Rigorous blood pressure and heart rate control is key to reducing that rupture risk. The target is usually a systolic pressure around 90, 110 millimiliter Gc, may be adjusted based on shock or brain injury, and a heart rate under 100 BPM. This minimizes wall stress. 4V beta blockers are the main tool, with close monitoring.
Centralization of care matters too.
Yes, outcomes are better in high-volume trauma centers with expertise in managing aortic pathologies, both open and endovascular.
The guidelines use a grading system for BTAI, similar to the general arterial one.
Yes, it aligns with the SVS 2011 system and mirrors the ESVS arterial grades. ESVS grade 1 is basically minimal injury, intima wall only, like SVS grade 3. ESVS grade 2 is a contained injury with abnormal contour, like a pseudoaneurysm, SVS grade 3. And ESVS grade 3 is free rupture or active bleeding, SVS grade 4.
How common are each of these?
In patients admitted to hospital, around 40% are grade 1, maybe 50% grade 2, and about 10% are the most severe grade 3.
Okay, now the big question. Management, particularly timing. Early versus delayed repair. This has been debated.
It has, and recent large database analyses has really shifted the thinking here. They found a significantly increased risk of death associated with early repair compared to delayed repair for certain injuries, even after adjusting for other factors.
It's counterintuitive. Why would delaying be better?
The thinking is that delaying allows for overall patient stabilization, resuscitation, management of other life-threatening injuries, like brain injury, and potentially allows the aortic injury itself to cool down or declare itself more clearly, all while under strict blood pressure control. It seems delayed repair in selected patients is safe and potentially preferable.
How does this translate into recommendations based on grade?
Okay, for ESVS grade 1 BTAI, minimal injury, without severe traumatic brain injury, non-operative management with blood pressure control and follow-up imaging is recommended. That's recommendation 44, class 1, level C.
So observe the minor ones if the brain is okay. What about grade 2, the contained injuries?
Here, the timing depends on whether there are high-risk aortic features, things like the size or shape of the pseudoaneurysm, which they detail in a table. Recommendation 47, urgent, 24-hour endovascular stent graft repair, TVAR, is recommended for patients with ESVS grade 2 BTAI with high-risk aortic features, Class 1, Level C.
And if there are no high-risk features in a grade 2 injury,
Then delayed repair is preferred. Recommendation 46. Delayed 24-hour endovascular stent graft repair should be considered for patients with ESVS grade 2 BTAI if there are no high-risk injury features. That's Class 2A, Level B. Note the Level B evidence here, reflecting those large database studies supporting delayed repair.
and grade 3, active bleeding.
That's an emergency. Recommendation 48. Immediate operative repair is recommended for patients with blunt thoracic aortic injury with active extravasation, ESVS grade 3. Class 1, Level C. No delay there.
It seems like TVAR, endovascular repair, is the preferred method when intervention is needed.
Generally, yes, for suitable anatomy. Studies, including the big AST prospective studies and meta-analyses, consistently show significantly better early outcomes with TVAR compared to traditional open surgical repair, OSR. Lower mortality, fewer blood transfusions, much lower rates of paraplegia and stroke. Especially in patients with other major injuries, TVAR seems beneficial.
But TVAR has its own issues.
Of course. Device-related things like endoleaks, problems at the access site in the groin, sometimes occlusion of neck vessels like the left subclavian or carotid if the stent covers their origin, rarely device collapse.
What about using heparin during TVAR?
It's a balancing act. Recommendation 49. Intraoperative systemic heparinization for a thoracic aortic stent graft repair should be considered individualized, including the perceived risks of blooding, especially with TBI, thromboembolic complications, and severity of TBI. Class 2A, Level C. Basically tailor it to the patient.
Sizing the stent graft seems important too.
Very. You need the right size, typically 10–20% oversized compared to the normal aorta diameter to get a good seal and avoid leaks or collapse. But in trauma patients who might be hypovolemic when they get their initial CT scan, the aorta might look smaller than it really is.
So you might need to oversize more.
Potentially. Recommendation 50. Stent graft oversizing between 20% and 30%, depending on the hypovolemic status during index CTA, should be considered for patients undergoing emergency TVAR. Class 2A, Level C. Getting a repeat CT scan once the patient is resuscitated and normovolemic can be really valuable for accurate planning if time permits.
What if the TVAR needs to cover the origin of the left subclavian artery? Do you need to bypass it routinely?
No. Recommendation 51. Routine left subclavian artery revascularization is not indicated for patients with BTAI requiring TVAR with coverage of the LSA. Class 3A, Level C. Don't do it routinely.
When is open surgical repair, OSR, still the way to go for BTAI?
It's reserved for selected patients whose anatomy just isn't suitable for TVAR. Maybe there's no adequate healthy aorta neck to land the stent graft proximally, or their iliac or femoral arteries are too small or diseased to get the device up there.
And the recommendation.
Recommendation 54. Open surgical repair is recommended in selected patients with BTAI requiring intervention and with an aortic anatomy unsuitable for a stent graft. That's Class 1, Level A. Note the strong evidence base here for OSR in this specific situation.
A key consideration during open repair is preventing paralysis.
Yes, paraplegia. Using active distal aortic perfusion, basically pumping blood to the lower body and spinal cord while the aorta is clamped, has become standard practice and significantly reduces the risk compared to just clamping and sewing quickly. The evidence strongly supports using perfusion strategies.
Okay. Lastly, for the thorax, what about subclavian artery injuries, blunt or penetrating?
These are challenging injuries in the thoracic outlet region. Preoperative CTA is really valuable for planning the incision and getting proximal control. Open exposure often requires complex incisions like a median sternotomy with neck extensions.
Endovascular is an option here too.
Yes, and it's increasingly used. Studies suggest endovascular repair with stent grafts, when feasible, might be associated with better outcomes, lower mortality, fewer infections compared to open repair for these difficult-to-access injuries. Long-term patency data is still limited, though.
So the recommendation for significant subclavian axillary injury.
Recommendation 55. Urgent repair with endovascular stent graft if anatomically feasible, or open surgeries are recommended for patients with significant subclavian or axillary artery injury and active bleeding or limb ischemia. Class 1, Level B repair is needed. Endovascular preferred if possible.
All right, quick micro recap for the thorax. BTAI, highly lethal, manage BPHR aggressively. Grade 1, often non-off, Class 1. Grade 2 timing depends on risk features. Urgent TVAR for high-risk Class 1, delayed TVAR considered for lower-risk Class 2A. Grade 3 needs immediate repair, Class 1.
TVAR generally has better early outcomes than open, but open repair is crucial for unsuitable anatomy, Class 1 Level A, and needs distal perfusion.
Subclavian injuries also need urgent repair, Class 1, with endovascular favored if feasible.
Got it. Let's move down into the abdomen now. Abdominal vascular injuries often present dramatically.
Often, yes. With major intra-abdominal or retroperitoneal bleeding, requiring massive transfusion, life-saving surgery, patients might even arrive in cardiac arrest needing a resuscitative thoracotomy, though survival is poor then.
But not always unstable.
Right. Some patients, maybe up to 30% with arterial injuries, are actually stable on admission, particularly those with contained retroperitoneal hematomas involving the IVC or iliac vessels. So hemodynamic status is really the key driver for initial management.
Immediate surgery for the unstable ones.
Absolutely. Recommendation 61. Immediate surgical exploration and hemorrhage control is recommended for patients in shock with ongoing bleeding and suspicion of major abdominal vascular injury. Class 1, Level C. You need to get in there fast, use damage control principles packing, maybe aortic compression at the hiatus if needed.
Okay. What about retroperitoneal hematomas found during that laparotomy? The guidelines say move beyond the old zone classification.
Yeah, that system was developed before widespread CTA and endovascular options. Hematomas don't respect those artificial zones. The current approach focuses on, is the patient unstable? Is the hematoma itself unstable, meaning expanding, pulsatile, or actively bleeding?
So if either the patient or the hematoma is unstable?
Explore it. Recommendation 62. Surgical exploration of retroperitoneal hematomas during trauma laparotomy is recommended in patients who are hemodynamically unstable or who have an unstable retroperitoneal hematoma. Class 1, Level C.
And if the patient A and D, the hematoma, are both stable?
Then you don't necessarily need to explore it right then. Recommendation 63. A non-exploratory approach of retroperitoneal hematomas during trauma laparotomy with subsequent computed tomography angiography imaging is recommended for patients who are hemodynamically stable, A and D, have a stable retroperitoneal hematoma. Class 1, Level C. Get a CTA later to figure out what's going on and if intervention is needed. Sometimes packing can temporarily control things until expertise arrives or the patient is transferred.
Let's talk specific vessels. Abdominal aorta injuries, blunt or penetrating. Can they ever be managed non-operatively?
Surprisingly, yes. For selected blunt abdominal aortic injuries, a large study found over a third were managed non-operatively with low failure rates. Most of these were minimal injuries, ESVS grade 1 intimal tears, or even some contained grade 2 pseudoaneurysms. Requires close follow-up imaging, though.
When is open repair needed?
Usually when aortic injuries are found during that initial damage control laparotomy for unstable patients. It's the most common repair type for penetrating aortic injuries. Also an option after blunt occlusive injuries, grade X, especially in younger patients, once diagnosed on CTA. Repair often involves synthetic tube or bifurcated grafts, which seem reasonably safe even with bowel injuries present in emergencies.
And endovascular repair for the abdominal aorta, EVR in trauma.
It's being used more. One study found 15% of blunt aortic injuries got endovascular repair. Another analysis using the National Trauma Data Bank found almost 30% had endovascular repair. And after adjusting for factors, the open repair group have much higher odds of death. So it shows promise.
The recommendation.
Recommendation 68. Endovascular stent graft repair should be considered as an alternative to open repair for abdominal aortic injuries in hemodynamically stable patients with suitable anatomy. Class 2A, Level C.
And the same caution about sizing applies as in the chest?
Yes. Recommendation 69. Stent graft sizing for abdominal aortic repair should be considered with caution if based on CTA performed during hypovolemia.
Sure.
Class 2A, Level C. The aorta might look smaller than it is.
Okay. Moving down to the iliac arteries. Rare but deadly.
Relatively rare, less than 2% of vascular trauma, but yet reported mortality is very high, up to 80% in some series, probably because they bleed massively into the retroperitoneum without tamponade. The common iliac is most often injured.
Management. Open repair for unstable patients.
Yes. Recommendation 72. Open surgical repair is recommended for unstable patients with common or external iliac artery injury. Class 1, Level C. It's very challenging surgery due to location and hematoma.
Shunting an option here too?
Yes, a damage control for unstable patients. Recommendation 73. Temporary shunting should be considered in damage control laparotomy for iliac artery injury in unstable patients with significant tissue destruction or inability to perform definitive repair. Class 2A, Level C.
Graft material if needed.
Synthetic graft is recommended if primary repair isn't feasible. Recommendation 74. Synthetic interposition graft is recommended for reconstruction of common or external iliac artery injury when primary repair is not feasible. Class 1, Level C.
And endovascular for stable iliac injury.
Yes. Recommendation 75.
Endovascular stent graft repair should be considered for common or external iliac artery injuries in hemodynamically stable patients with suitable anatomy. Class 2A, level C, similar logic to the aorta.
Okay, last group in the abdomen, major venous injuries. IVC, portal vein, renal veins.
These are tough. Let's start with the IVC, the inferior vena cava. Patients can actually be stable initially if the hematoma is contained.
Non-operative management possible then.
Yes. Recommendation 80. Non-operative management with close observation and follow-up imaging should be considered in hemodynamically stable patients with IVC injury and a stable retroperitoneal hematoma. Class 2A, level C.
If you do operate, repair versus ligation.
Minor injuries can be repaired with sutures, larger defects. You might try a temporary shunt or ligation. Ligation is often part of damage control in really sick patients. The evidence comparing ligation to repair is mixed. Some older studies suggested higher mortality with ligation, especially above the renal veins. More recent analyses, maybe reflecting better critical care, haven't always found ligation independently linked to death, though maybe to other complications like kidney injury. Propensity score matching didn't show ligation was superior to repair for mortality. It's complex, highly individualized. Endovascular stent grafts for IVC trauma are rare, but have been used successfully in case reports.
Portal and superior mesenteric veins.
Very high mortality injuries. Repair with sutures is attempted if possible. Ligation is a salvage option in damage control, but carries a high risk of bowel ischemia and death.
Renal veins.
Very little evidence here. Generally, repair by suture, venorrhea, is recommended whenever feasible. Recommendation 82, Class 1, Level C. Ligation may be considered if repair isn't possible. Class 2B, Level C. Ligating the left renal vein near the IVC is usually tolerated due to collaterals, but ligating the right renal vein usually means loss of the right kidney.
Okay, micro recap for the abdomen. Stability drives everything. Immediate surgery for unstable, Class 1. CTA for stable, Class 1. Manage retroperitoneal hematomas based on stability, not just zones. Class 1, REX for explore versus observe. Endovascular is an increasing option for stable aortic or iliac injuries, Class 2A, but open repair, shunting, Class 2A, and ligation remain vital, especially for unstable patients and complex venous injuries. Be cautious sizing grafts in hypovolemia, Class 2A.
Exactly. Abdominal vascular trauma requires rapid assessment, stability-driven decisions, and often a combination of damage control and definitive techniques, with growing endovascular options for the stable patient.
Right. Let's move out to the limbs now, extremities, a very common site for vascular injury.
Very common. Can range from minor wall injuries to complete blockages causing severe ischemia. Initial assessment relies heavily on physical examination.
But just to hammer the point home again, ABI.
Not for diagnosis and trauma. Recommendation 83. ABI is not indicated to diagnose or rule out vascular injury. Class 3A, Level C. Clinical exam is key.
Imaging for suspected extremity injury.
CTA, again, for stable patients. Recommendation 84. CTA is recommended as the first-line investigation to identify or rule out arterial injury in hemodynamically stable patients with suspected extremity vascular trauma. Class 1, Level C.
But time is critical here, right?
Absolutely critical. Imaging must be prompt and must not delay treatment if the limb is obviously ischemic. In urgent cases, you might need to go straight to the OR without imaging.
You mentioned earlier there's no safe window for ischemia. Can you expand on that? The golden hour idea.
Yeah, the old teaching of a 6-hour window based on elective embolectomy doesn't really hold up in trauma. Recent data is pretty clear. The faster you revascularize, the better the outcome. One large U.S. registry study found amputation rates were significantly lower if revascularization happened within 60 minutes compared to 1 3 hours or 3 6 hours. Military data suggests a linear decline in limb salvage probability with every hour of delay.
So the recommendation reflects that urgency.
Yes. Recommendation 85. Revascularization as soon as possible, ideally within 1 hour of admission, is recommended in patients with clinical evidence of acute ischemia due to extremity vascular trauma. Class 1, Level C. Treat it like a time-critical emergency.
And prioritize flow restoration over other things.
Yes, same principle as we discussed earlier. Recommendation 86 reiterates that using a temporary vascular shunt to rapidly restore blood flow is recommended when timely primary definitive repair isn't feasible due to physiology or skeletal instability. Class 1, Level C. Get the blood flowing first.
When it comes to definitive repair, open surgery is still the standard.
For extremity vascular trauma needing repair, yes, open surgery is the standard. The type of repair depends on the injury grade and extent, maybe simple suture, a patch, or often an interposition graft or bypass.
Preferred graft material.
Autologous vein, usually the saphenous vein from the leg, or sometimes arm vein is preferred. It resists infection better, can potentially grow in kids, and resists kinking. Reverse saphenous vein graft is the workhorse. Synthetic grafts are an option if vein isn't available, but they have higher risks of infection and later failure, especially in contaminated wounds.
What about really complex injuries, maybe combined bone and vessel trauma?
These require a team approach. Recommendation 88. Multidisciplinary decision-making regarding revascularization versus primary amputation is recommended in patients with complex extremity trauma. Class 1, Level C. Sometimes amputation is the better, life-saving option.
Okay, what about those less severe non-occlusive injuries? ESVS grade 1 or 2 in the extremities. Endomal flaps, small pseudoaneurysms that aren't blocking flow.
This is a therapeutic dilemma. We don't fully understand their natural history, and the evidence for management is generally low-quality case series, small retrospective studies.
What do those studies suggest?
Some show that many patients managed non-operatively do fine, maybe only a small percentage need later intervention. Others show some injuries worsen over time. It's not clear-cut.
So what's the guideline?
Based on this limited data, they suggest a selective approach. Recommendation 89. Selective non-operative management with close clinical observation and scheduled duplex ultrasound follow-up should be considered for patients with non-occlusive extremity vascular injuries, ESVS grade 1 or 2. Class 2A, Level C. The key is selective. The patient needs to be reliable, able to come back for follow-up DUS scans.
Got it. Now, what about endovascular repair for extremity injuries? Stents, stent grafts?
It's being used more, but still in less than 20% of cases overall. Comparative studies are a bit mixed. One large propensity-matched study found endovascular repair had a higher risk of readmission and higher 30-day open reoperation rates compared to open, though no difference in mortality or amputation. Other studies also raised concerns about long-term patency and reintervention risk. One analysis even suggested higher mortality with endovascular for isolated femoral popliteal injuries after adjusting for factors.
So not a clear win for endovascular in extremities yet.
Not based on the current evidence presented here compared to open repair. The recommendation reflects this uncertainty. Recommendation 90. Endovascular stent or stent graft repair may be considered as an alternative to open repair in selected patients with extremity vascular trauma requiring operative treatment, ESVS grade 2, 3, or X. Class 2B, Level C. It's an option, but a weaker recommendation than for open repair.
But there's one area where endovascular shines in extremities.
Yes, embolization for bleeding from side branches. If you have bleeding from smaller tributary arteries off a main vessel, coiling or plugging them via endovascular access is very effective. Recommendation 91. Endovascular embolization is recommended for active bleeding from side branches of major arteries in patients with extremity injuries. Class 1, Level C. Strong recommendation for that specific scenario. Intraoperative heparin during extremity repair. Again, individualized. Recommendation 94. Intraoperative systemic heparinization may be considered on an individual basis. Class 2B, Level C. Considering the repair complexity, ischemia time, other injuries, bleeding risk, and how coagulopathic the patient is.
Extremity venous injuries, repair or ligate?
It depends. Combined arterial and venous injuries are more severe, higher risk. In unstable patients or those with overwhelming injuries, ligation or maybe temporary venous shunting might be preferred. But for more isolated injuries in stable patients, repair might be better. A meta-analysis suggested lower amputation risk with venous repair versus ligation, without increasing VTE risk, but the evidence isn't definitive.
So the recommendation for femoral or popliteal veins?
Recommendation 95. Repair of localized femoral or popliteal venous injury should be considered over ligation in hemodynamically stable patients, Class 2A, Level B. So, for those major veins in a stable patient, lean towards repair.
Finally, compartment syndrome and the idea of prophylactic fasciotomy.
Compartment syndrome itself is a surgical emergency. High clinical suspicion is key. If the signs are there, pain out of proportion, tense compartment, pain on passive stretch, you need urgent fasciotomy. Measuring compartment pressures can help in unclear cases, like unconscious patients. Ischemia duration over 2.5 hours is a strong predictor.
But what about doing fasciotomies before signs develop, just based on risk, prophylactically?
That's controversial. The guidelines explicitly state this. There's debate. Does it prevent complications or just add morbidity, like infection or nerve injury? Studies are conflicting. Some suggest benefit, others no benefit or even harm. There's no clear consensus. Therefore, the guidelines don't make a specific recommendation for or against prophylactic fasciotomy in this section, just highlight the controversy.
Okay, micro recap for extremities. ABI is out, Class 3A. CTA for stable patients, Class 1, but don't delay urgent treatment. Revascularization time is critical, ideally 1 hour, Class 1. Shunts are vital bridges, Class 1. Open repair with vein is standard. Non-occlusive grade 12 can be selectively observed, Class 2A. Endovascular repair may be an alternative for some operative cases, Class 2B, but embolization for side branch bleeding is strongly recommended, Class 1. Repair major veins if stable, Class 2A. Prophylactic fasciotomy remains controversial.
That covers the key points for extremities. It's a common area, time-sensitive, with clear priorities, but also areas like non-occlusive injuries and prophylactic fasciotomy, where practice varies due to limited high-quality evidence.
Let's look briefly at postoperative considerations. What happens after the initial surgery?
The post-op phase has its own challenges. Follow-up can be difficult. Patients might not come back, they see multiple doctors, rehab adherence varies, plus socioeconomic barriers and the psychological impact of trauma.
So a team approach is needed afterwards, too.
Definitely. A multidisciplinary, patient-centered approach helps improve compliance and outcomes. The post-hospital plan is crucial medications, appointments, maybe transfer to rehab. Psychological support is often needed. Regular visits and sometimes imaging like ultrasound or CT check how the repair is doing.
What about routine antibiotics after the vascular repair itself, beyond the initial trauma dose?
There's actually no specific evidence cited here for or against routine postoperative antibiotic prophylaxis just for the vascular repair component. It seems reasonable to individualize based on the overall picture. Was it an open fracture, heavy contamination, type of repair?
And antithrombotic therapy after the repair is done. Antiplatelets.
Anticoagulants.
Recommendation 98 suggests postoperative single antiplatelet therapy may be considered for patients who have undergone open or endovascular repair. Class 2B, level C. Again, it's a may consider reflecting limited strong evidence specifically for post-vascular trauma repair. Clinical judgment plays a big role here. So the post-op phase involves managing complex patient factors and navigating areas where specific evidence for vascular repair follow-up, like antibiotics, antithrombotics, is still developing.
Exactly. The initial fix is vital, but the journey continues well beyond the OR.
Let's turn now to pediatric vascular trauma. Thankfully rare, but with unique challenges.
Very rare. Less than 1% of pediatric trauma admissions. And because it's rare, there's a general lack of high-quality clinical evidence, making firm recommendations difficult. The guidelines present the best available data.
What are the unique challenges?
Smaller arteries are prone to spasm. Kids have smaller blood volumes. Repairs need to accommodate future growth, both in length and diameter, which makes conduit choice and technique tricky. Long-term durability is a bigger concern. On the plus side, kids can compensate well sometimes, which might support non-operative approaches in some cases. CTA is the most reported modality, seems to have high accuracy. Recommendation 99. CTA is recommended as the first-line investigation in hemodynamically stable pediatric trauma patients. Class 1, level C. Same as adults if stable.
Repair challenges you mentioned.
Choosing the right conduit is tough, especially in infants. No good studies compare vein versus synthetic. Vein might be better for small vessels. Techniques like using interrupted sutures instead of continuous ones are described to try and avoid narrowing the repair as the child grows. Vein grafts might dilate over time. Synthetic grafts might be needed for rapid flow restoration with size mismatch, maybe sewn with some slack for growth. Endovascular experience like TEVAR for aortic injury is growing but limited by device sizes.
Neck injuries in children. BCVI.
Incidents might be similar to adults. Data on management is sparse. Small studies suggest a selective, individualized strategy is safe. Minor lesions, grade 12, can be treated with antiplatelets or anticoagulants. No strong evidence favors one. The one small study hinted at better healing with antiplatelets. Recommendation 100. Early antithrombotic therapy is recommended for children with blunt, low-grade carotid artery injury, ESVS grade 1 or 2. Class 1, level C. For enlarging pseudoaneurysms or active bleeding, grade 23, embolization or open repair are options.
Abdominal trauma in kids.
For unstable kids with suspected major abdominal vascular injury, the approach is the same as adults. Recommendation 102. Immediate surgical exploration and bleeding control is recommended. Class 1, level C.
Extremities are the most common sight in kids, too.
Yes. Upper extremity more than lower. Blunt trauma, falls, traffic accidents, more common in younger kids. Penetrating, clasp, knives, in older ones. Repair is often possible, maybe primary repair. Interrupted sutures again mentioned for growth. Long-term complications seem rare after repair, even if grafts block later. Clinical vascular exam, just like adults, is recommended for all kids with extremity trauma.
recommendation 103, class 1, level C, to look for bleeding or ischemia.
There's a classic pediatric scenario, the supracondylar or humeral fracture at the elbow.
Yes, the most common elbow fracture in kids associated with brachial artery injury in up to 12%. Priority is always closed reduction and fixation of the fracture first.
What if the hand looks bad afterwards?
If the hand is poorly perfused, pale, cold after reduction, that needs immediate surgical exploration of the artery. However, if the hand is pink and warm but still pulseless, after reduction, the pink pulseless hand, there's support for expectant management. Recommendation 104. Non-operative management should be considered in a child with a pink and warm but pulseless hand post-supracondylar humeral fracture reduction, with close observation for the development of acute ischemia, class 2A, level C. This is a key specific pediatric point.
Post-op care for kids, antithrombotics. Follow-up.
No standard antithrombotic protocol. Antiplatelets or weight-based LMWH are suggested. Follow-up usually involves clinical exam and color duplex ultrasound. Recommendation 105. Post-operative follow-up with clinical examination and DUS 1 month after repair may be considered for extremity reconstructions. Class 2B, level C. Avoid surveillance CTA if possible due to radiation.
And TVAR for aortic injuries in kids.
Recommendation 101. Endovascular stent graft repair should be considered as the first-line operative treatment for children with BTAI, grade 2 or 3, and appropriate anatomy, class 2A, level C, an option acknowledging limitations.
So pediatric vascular trauma, rare, challenging, limited evidence. Apply general principles but consider size, growth. CTO if stable, class 1. Antithrombotics for low-grade blunt carotid, class 1. Clinical exam for extremities, class 1. Pink pulseless hand post-supracondylar reduction might be observed, class 2A. Multidisciplinary team essential.
Exactly. It really highlights the need for specialized care and more research in this specific population.
Which brings us neatly to the final section, the gaps in evidence and recommendations for future research. The guidelines are quite open about what we don't know.
They are, and that's a strength. They acknowledge that despite this comprehensive effort, significant gaps remain. Vascular trauma research, like trauma research generally, needs more large-scale prospective studies, more RCTs. Often, management still relies heavily on surgeon discretion based on the specific injury, patient physiology, contamination, and circumstances like mass casualties.
Trauma research funding hasn't kept pace with the burden.
Historically, no. Though they note increasing efforts through research networks and multi-center collaborations. They even mentioned the potential role of AI in predicting outcomes like limb salvage.
What are some of the key specific research priorities they identified?
Oh, there's a long list in Table 12. General things like needing better epidemiology data, finding the optimal duration for temporary shunts, refining patient selection for REBOA, understanding long-term outcomes after endovascular repairs, proving the benefit of hybrid ORs, evaluating newer graft materials, and figuring out the best anticoagulation strategies after trauma repair.
And for specific body regions.
YEC. Best antithrombotic regimens for BCVI, comparing antiplatelets versus LMWH, optimal follow-up intervals, thorax, role of non-op for low-grade BTAI, TVAR timing with TBI, predicting rupture risk, long-term device durability, sizing in small ear gaskets, surveillance protocols, abdomen, managing mesenterocranial injuries better, comparing IVC ligation versus repair prospectively, extremities, deciding revascularization versus amputation in complex cases, comparing open-endo long-term, managing occult injuries, venous injury strategy, post-op surveillance and thrombotics.
That's a huge research agenda. It really underscores that these guidelines are a snapshot in time, and clinical judgment remains critical where evidence is lacking.
Absolutely. These gaps mean ongoing research and integrating guidelines with clinical expertise are essential.
The guidelines also thoughtfully include a section summarizing the patient's perspectives.
Yes, which is important context. It explains vascular trauma, simply injury to arteries or veins, causing bleeding or clots, often in limbs, from falls, accidents, violence. It emphasizes the multidisciplinary team approach and the need for specialized centers.
It reiterates the priorities from the patient view.
Right. First, control bleeding, as it causes many early deaths. Second, restore circulation to save organs or limbs. It broadly describes treatments: observation, ligation, open repair with sutures or grafts, vein or synthetic, and minimally invasive endovascular options like plugs or stent grafts.
And highlights the recovery journey.
Exactly. Recovery is different for everyone. The post-hospital plan is vital meds, appointments, maybe rehab. Associated injuries need care too. And crucially, the psychological impact trauma causes strong emotions, maybe delayed reactions, needing professional help. Regular follow-up, sometimes with imaging, checks the repair.
The overall message for patients.
It's a serious condition. Risk of life or limb loss is real. But modern trauma care in specialized hospitals with multidisciplinary teams significantly improves outcomes. It's a good reminder of the human story behind the clinical details.
So we have taken a truly deep dive into these comprehensive European Society for Vascular Surgery 2025 guidelines on the management of vascular trauma.
We really have. We've gone from the methodology and that crucial grading system, class 1, 2A, 2B, 3, levels A, B, C, which helps you weigh every recommendation, through the general principles like epidemiology, team needs, resuscitation, imaging, and key shifts like the evidence against routine REBOA.
And we systematically explored management across the neck, thorax, abdomen, extremities for penetrating and blunt injuries, discussing open versus endo, shunts, venous challenges, compartment syndrome, even the unique aspects of pediatric trauma.
And we finished by acknowledging the significant evidence gaps that remain, highlighting future research needs, and remembering the vital patient perspective.
It's been a huge amount of information, pulled directly from the source, aiming to give you that comprehensive understanding for your clinical practice.
These guidelines definitely provide a robust framework. But, as the authors themselves stress, clinical judgment is always paramount, especially where the evidence isn't rock solid.
And here's where it gets really interesting, perhaps the most challenging part. Given those acknowledged limitations and high-quality evidence for many recommendations, especially the Class 2 or Level C ones, and thinking about how fast endovascular tech evolves, often with less long-term data than older open techniques, how do you, the listener, actually synthesize these detailed guidelines with your own hard-won clinical experience, the specific resources you have access to at your hospital, and the unique, messy reality of a complex patient who doesn't quite fit neatly into a Class 1 Level A box?
That integration, evidence, experience, context, that's the real art of applying these guidelines effectively day to day, isn't it?
It really is. That's definitely something to mull over as you reflect on this deep dive. We hope this detailed exploration provides immense value in your practice.